This is a continuation of our cardiology lecture. Keep in mind that the heart runs on electricity, and there can be some causes of malfunctions that are electrical in nature. The electrical impulses that are generated within the heart are responsible for the heart's rhythmic beating that pumps blood throughout the body. A malfunction of the heart's electrical system results in what's known as a dysrhythmia or an arrhythmia, which is classified as an irregular or completely absent heart rhythm. Some terms that you really need to be very familiar with are bradycardia, which is a heart rate of less than 60 beats per minute, and tachycardia, which is a heart rate of greater than 100 beats per minute. Ventricular fibrillation is when the heart just kind of sits there and quivers. All of the cells in the heart are firing at the exact same time, and there's no pulse, therefore there is no cardiac output, and your patient's in cardiac arrest. Ventricular tachycardia is a rhythm that is very fast, and it can either have a pulse or it can be absent of a pulse. This rhythm primarily is a very poor, provides very poor cardiac output for your patient. Pulseless electrical activity means that there's electricity in the heart, but there's no mechanical action, there's no pumping action. And asystole is just basically what we know as flatline. There's no electricity going on whatsoever. This is the most difficult rhythm to get your patient out of. Now, a number of complications is sometimes seen with a MI or myocardial infarction is mechanical pump failure, also known as heart failure, or sometimes you'll hear me refer it to as congestive heart failure. Now, keep in mind that a lack of oxygen causes the death of the portion of the myocardium. The myocardium is the muscular portion of the heart. It's the working portion of the heart that contracts, that moves blood in and out of the heart. If we've got a large area that dies, the pumping action of the whole heart is affected, causing cardiac arrest, shock, pulmonary edema, or fluid that begins to back up in the lungs, ultimately leading into heart failure. Some patients can suffer a cardiac rupture days after a heart attack. And basically, this is just a portion of the heart that kind of blows out. Now, that's not a massive blowout of the heart. And keep in mind, the largest part of the heart is the left ventricle itself. But you have a certain portion of the heart that just kind of ruptures. Also, keep in mind that when a patient has an MI, it no longer, that part of the heart that is dead, infarcted, or necrosed, no longer, number one, conducts electricity, or no longer is an effective pump, and the patient's quality of life begins to be negatively impacted. Now, we have valves in the heart as well. If you'll go back to when we talked about a little bit about movement of the blood through the heart, into the lungs, back to the heart, and then out of the heart. And if you're not really familiar with that, I'd strongly encourage you to get into your textbook and review that section of where blood is moving in and out of the heart, the physiological action of that. Between the atria and the ventricles, we have valves. And sometimes these valves get diseased, sometimes they are congenitally malformed, and they can lead to backup of fluid, or the medical term for that is known as regurgitation, into other parts of the body. And this is a common cause of heart disorders, cardiovascular disorders. Most of the time, these are relatively easy to fix by way of surgery. Now, during times of exertion or stress, the heart works harder, and the portion of the myocardium supplied by the narrowed artery that is blocked off with a clot or fat or a thrombus becomes starved for oxygen, because it's kind of like a traffic jam out on the interstate where you've got We got 3 lanes that come through Richmond, and if the right 2 lanes are blocked off because of a wreck, then traffic slows down, everything backs up, and the number of cars that gets through becomes delayed. The exact same thing happens in the heart. We get this blockage. Sometimes it's complete, which leads into patient having an MI. Sometimes it's not complete and it's only partial, which leads into our patient having a condition known as angina pectoris, where the demand for oxygen becomes greater than the available supply. When the myocardium, or the heart muscle, is deprived of oxygen, angina pectoris, we typically just call it angina, is the most frequent result, and that typically comes about with some type of chest pain or chest discomfort. Now, the thing about angina is that you have 2 forms. You have stable angina and you have unstable angina. Stable angina happens when the patient, when the pain that the patient is having from angina stops doing whatever they're doing. Or the other thing is that they may take a medication known as nitroglycerin. Now, nitroglycerin, if you'll remember, and we kind of talked about this as far as nitrogen washout on giving patients oxygen, the primary ingredient is nitrogen. As a result, what it does is when we give our patient nitroglycerin, it dilates the blood vessels all through the body, but in particular within the heart, so that there is more blood that's able to get through with less friction, and so the blood vessel becomes larger, and we can get more oxygenated blood around the heart. Now, going back about stable angina for your patient is predictable. Patient climbs up 1 flight of stairs. He or she knows that when I get to the top of the stairs, I'm going to have chest discomfort, going to have a little shortness of breath, and I'm going to have to rest just a little bit, okay, maybe 30 seconds or a minute. It goes away. The law of supply and demand balances out. So supply equals demand. Chest discomfort goes away, shortness of breath goes away. I'm able to climb up another flight of stairs. Unstable angina is when that patient now gets to the top of the stairs, and now instead of maybe what they normally have to do as far as a minute, now they're going to have to wait 5 minutes for that to go away. So there's a change in the type of pain and the length of pain. That's unstable angina. That tells us that the blockage has worsened. With nitroglycerin, many times patients can deal with it with, let's say, 1 spray or 1 tablet of nitroglycerin for the patient. They take it themselves. That's stable angina. Unstable angina, however, comes into play now. Instead of 1 spray, now they maybe need 2 or 3. And so this is the role where nitroglycerin plays as far as the importance of dealing with the chest pain. And you can assist your patient with taking the nitroglycerin, as we'll talk about in just a minute. Now, understand that nitroglycerin, or we commonly shorten it down, just simply call it nitro, comes in tablets, patches, as well as in sprays. Now, the normal course of helping a patient take their nitroglycerin would be to take 1 dose, which is 0.4 milligrams per spray or per tablet, and that they would take these doses over a 10-minute period. So basically you would wait and take a dose. If the pain has not gotten any better, then you could give another dose 5 minutes later. Pain has not gotten any better, you can give a 3rd dose 5 minutes later. Now, some of the things that are critical to understand is that because nitro causes a massive vasodilation, it's also going to drop the blood pressure. One of the things that we don't do is that we do not want to help our patient take nitro, and it's got to be their nitro, not somebody else's, if their blood pressure is less than 90 systolic. That's key. That's a cutoff. The other thing that we look at in here is that the presence or absence of taking erectile dysfunction drugs. ED drugs cause vasodilation within the body, and giving nitroglycerin to a patient that has taken an ED drug can also make that worse. So basically what we're looking at is that we have both absolute or relative contraindications. An absolute contraindication is we don't give it, period, end of story. A relative contraindication is depending upon the circumstances, we might give a medicine or we might not. In the case of the patient that is having chest pain, that has their nitroglycerin, it's prescribed to them and it's in date. One of the things that we would look at here would be if they tell us that they've taken an ED drug, Viagra, Cialis, we need to find out how long ago did they take it. If they took it within the last 12 hours, that's going to be an absolute contraindication. You should still get on the phone or the radio with your med control at the ER and confirm with med control of what they want you to do, but I can guarantee you almost all the time they're simply going to tell you transport the patient without giving nitroglycerin. If it's been between 12 to 24 hours, it all depends upon what the patient's blood pressure is going to be. If the systolic blood pressure is like 110, 120, the doctor will probably tell you, again, this is if the patient has taken an ED drug within the last 12 to 24 hours, administer one dose and transport. Don't repeat the dose. If the patient's blood pressure, systolic blood pressure is like 102, 104, they're probably going to say, don't give any of the nitroglycerin and just simply transport. This gives kind of a buffer zone to allow the patient's blood pressure to drop safely because we're basically kind of playing into the future. We're not entirely sure how far the patient's blood pressure will drop, and so it allows that buffer. So I'm going to stop right there, and then I will pick up with additional lectures, recordings, and we'll also, whatever we don't get done as far as recordings, we will take care of in class next week. So review this material, and I will talk to you later.